Hello, I'm Dr. Adam Friedman, professor and chair of dermatology at GW School of Medicine and Health Sciences. Welcome to this program titled Let's Get Social about Pediatric Hives, Foundations for Frontline Care. I'm joined today by Dr. Payel Gupta from Mount Sinai and SUNY Downstate Medical Centers. Welcome, it's so great to have you here.
So great to be here. So first we're going to start off by talking about the prevalence of pediatric urticaria. So pediatric urticaria is actually very common, though figures vary by study and population. Up to 25% of children will experience urticaria. And while it can affect children of all ages, it often is more frequent in younger children, which I'm sure you've seen in your practice.
Absolutely.
And there's no specific gender, so predominance. It can affect boys and girls equally.
Yeah, I mean, it's an interesting point because when we use the term urticaria overall, I think that means a couple different things. And I really like to delineate between the flavors as distinct diseases. But first, you got to make the right diagnosis. And I think that is a challenge because all urticarias are a clinical diagnosis. And being able to recognize those key features that delineate it from urticarial things that look like hives, is of the utmost importance. So what are the key things when we're thinking about the actual features of urticaria? These are going to be sharply defined, well cut off dermal plaques, which means that there's no surface change. There should be no scale, no crusting, unless the person's really picking at it. But that's very unusual because by definition, these spots don't last very long. And I think that's the most important point. It is the fact that each individual plaque, each individual rash should only last about 24 hours, maybe pushing about 36 hours. And yes, they can move around, but how we ask it, or as a parent asking their child, will that spot on your arm be there tomorrow? The answer is no, then you're probably in the world of hives. And then looking at it, I think we talk about the wheel and flare, this perfect fluffy round circular plaque. Atypical is typical when it comes to the skin. And I think that you can get snake-like, swirly types of plaques. It doesn't have to be a perfect circle. The defining feature is it's there for less than 24 hours. There's no surface change. And I think also the itch is very defining. It's kind of like a burning itch, and it doesn't really feel that great to scratch as opposed to things like eczema. Now, angioedema is a little bit different. This tends to be a little bit more painful, a little bit more burning. You may not necessarily see the redness or the off-white or pink or purple that you would expect from hives, but rather it's more of a swelling. And it has a predilection, I think, for areas that can stretch a little bit easier. So the lips, the eyelids. The length is a little bit different too when it comes to angioedema versus hives. It's usually about 72 hours, so about 3 days, and then it'll go away. So that coming and going is still a piece of the puzzle, but it lasts a little bit longer.
Yeah, and urticaria can be classified in two different ways. And really it's duration and the role of triggers. So talking first about duration, we think about it as acute versus chronic, right? And so acute is less than 6 weeks and chronic is greater than 6 weeks. And it's really important to remember that distinction because it changes the way that we think about the urticaria. And then the role of triggers is inducible versus spontaneous. And what we mean by inducible is that there is a trigger and hive relationship, right? And so when you have that specific trigger, whether it be pressure, cold, stress, any of these things, then you will have hives directly after that, right? And so that's what we think about with inducible. Now, with spontaneous, these hives can come and go, and it really doesn't matter. You can wake up with them, you could be literally anywhere, and they will come and go, and it's not related to any specific trigger.
Yeah, I think that's such an important point because I think in general, we want to know what's causing, for example, on the skin. What is the root cause, which I know you and I hear about, and we get a little bit of a nervous tick when we hear that term because there is no root cause. And that, I think, the historic name, chronic idiopathic urticaria, really highlighted that in terms of we don't know the why, we just know the what. I like the name change because the spontaneity of the disease, the fact that you're right, you can be out and about doing your business, watching TV, you could be at a wedding, a childbirth, and all of a sudden head to toe within a matter of seconds. And I think that unique kind of unpredictability or the spontaneity actually adds to the burden of disease, why it's so important to identify and make the right diagnosis, but also get on the right treatment.
Absolutely.
So what are some red flags that you, and we'll kind of get into this, you think kind of push you away from the diagnosis? Because, we talk about that urticaria is defined based on time, right? So a single plaque, a single rash only lasts about 24 hours. Angioedema lasts about 72 hours. There are times where you see something that looks like a hive, but it's not and can indicate something else. So first and foremost, that timing is everything. And as you so beautifully pointed out, the individual lesion, less than 24 hours, but to define acute versus chronic, the line in the sand is going to be 6 weeks. Less than 6 weeks, it's acute, which I think is a different disease. And in that case, I think we can sometimes put our finger on what's causing it. I always like to say food, drug, or bug. Somewhere between the three, it's probably the driving force for this one-off of hives for a couple weeks and it goes away and you're done. Whereas after 6 weeks, you're not going to be able to really pinpoint anything. It is spontaneous, it's idiopathic, aside from those inducible triggers like scratching, temperature change, and water. But when you go against that kind of mentality of timing and something lasts longer, then we're thinking about more urticarial. So if you have hives that last longer than 48 hours, it's not actually hives. To me, I think probably the most important thing is if you have hives plus. So you have hives or hive-like rashes that are associated with joint pain, fevers, overall just feeling kind of lousy. That to me is a flag, a red flag at that. Not to mention with angioedema, when we're talking about angioedema in the combination with chronic-spontaneous urticaria, we're not really thinking about your throat's going to close up, you're not going to be able to breathe. That's very different than the intense kind of swelling of your breathing tube, so to speak, where you actually can go downhill very quickly. That is very different. We don't expect that with the angioedema of hives or in combination with chronic spontaneous urticaria. So if someone is having difficulty breathing associated with swelling, that to me also is a red flag. What about for you? What are some, we got to jump on this real fast because this could be considerably concerning.
Absolutely. So this is a big deal because oftentimes these patients go to the emergency room or
Right.
urgent care, and that's where they're seen. And our colleagues in the urgent cares and emergency rooms, their job is to keep this person safe, right?
Right.
And so oftentimes they're diagnosed with anaphylaxis. And anaphylaxis is a very particular condition, right? And usually it's associated, as you mentioned, with angioedema of the airways, right? Of the larynx, of this where you can stop breathing, right? And so these patients really have superficial angioedema.
Right.
They don't have angioedema of their airways. And so absolutely, they don't have vomiting, nausea,
Right.
wheezing, chest tightness, all of these symptoms that are associated with true anaphylaxis. And so it's very important to keep that in mind, right? It's very important to have that distinction in mind so that we're not actually provoking fear in patients, right? Thinking that you could have anaphylaxis every time you have hives is very scary for patients. And so that's why, again, as you pointed out, it's just so important that we make the diagnosis correctly.
Yeah, I think to that point, the lexicon is not very defining. You say urticaria, could be acute, could be chronic, could be inducible. Angioedema could be the superficial. And I love how you put that. It's superficial angioedema. This is not affecting deeper structures as compared to anaphylaxis, a concerning type 1 hypersensitivity, but the terms are used interchangeably. So I think defining that is really important. So if you have chronic spontaneous urticaria, you have angioedema, that is a very different scenario. And so yes, you should not be running to the ER every time you have a flare because being a chronic disease, it's gonna keep happening until it's medically managed appropriately.
So next, we've kind of touched on this, but how are we diagnosing this? It's really the physical exam. And
Right.
physical exam is so important. And oftentimes patients don't come in hiving, right? It's like the one moment in their day.
The invisible dermatosis,
right.
yeah.
It's the one moment in their day, like they're hiving all day, every day, but obviously when they come
Right.
into the doctor's office, magically all the hives are gone. And so, and that's common, right? We see that and it's not a big deal, but that's why taking pictures and videos of the lesions when they are happening
Right.
before your doctor's visit is so important for these patients. And I tell other providers, family practitioners, internists, that it's very important that they tell their patients to do that so that they are able to really look at the lesions and make sure that they do look urticarial, right? And then the other thing is that in different skin tones, sometimes we also get misdiagnosis, right? And the time to diagnosis is longer because they may not appear in those red kind of lesions. They may be more purple. They may just look different. And so it's really important for practitioners to understand what urticaria can look like in different skin tones. Yep. And then the really important thing as an allergist that I want to point out, especially to my colleagues in other fields, is that we're not going to likely test these patients for allergies, right? So unless we think it's an acute urticaria in response to an allergic reaction to a food, we are not going to test them. And it really has to be a one-to-one correlation with that. You eat the food, within minutes to maximum 30 minutes, you start having the symptoms. And again, they're usually associated with difficulty breathing, nausea, vomiting, and additional symptoms, not just hives and angioedema, as we discussed. And so it's important to remember that we're not going to be testing these patients. If they have other symptoms that look like environmental allergies, like runny nose, itchy eyes, they have seasonal symptoms, they want to get tested for environmental allergies, we may do that. But we will never do a food allergy panel in these patients because there's false positives, which means that we will get tests that look positive that have nothing to do with the hives or the angioedema. And that's very important also because when patients may go online to get food allergy panels done and they get a bunch of false positives, they start basically participating in a very restrictive diet. So we've also seen patients come in with almost failure to thrive because they're not really eating anymore because they're trying to take everything out of their diet in order to prevent these hives from appearing. So, you know, diagnosis is just so important. And the way that we're coming to this diagnosis and then what we're doing as a follow-up is also very important to remember.
You hit on so many important pearls, like a hamster running on a wheel in my brain right now. So to your point about even the diversity of clinical presentations, you know, especially in darker skin individuals, the flare isn't so obvious. I've actually seen many patients where it's white. It's just the pallor from the edema, the water in the skin, blanching out the skin. And so it's really important, one, not to be too rigid in this is how we diagnose, this is what it's supposed to look like. But also along the lines from the patient perspective, we need to ensure that the accessible resources for patients include images across the spectrum of skin tones, because what does someone do when they see a rash? Yes, they want to try to get an appointment near you, but that takes time. They go to good old Dr. Google and they will look at Google image. And so if you don't have images of even common skin conditions like chronic spontaneous urticaria across the spectrum of skin tones, they may not see themselves in it and go in a different direction. I loved your point about kind of talk more, lab less, you know, and that's really important because often patients will come in with the expectation of a lot of labs, or even for me, a skin biopsy. And that could be a tough conversation because they've come to terms like, I'm going to get poked and prodded. And you're like, no, you don't have to do that. And it kind of disrupts their perception and their vision of how the visit's supposed to go. So we can do ourselves a really big favor by setting the stage and, to your point, saying that a massive workup is not necessary. It's all in the story. It's all in the physical exam. Now, when you look at the guidelines, there are some recommendations for certain labs depending on the situation, but let the review systems guide that, not necessarily saying, oh, I think you might have hives. I think you might have angioedema. Let's run a full battery of tests. Because you may find nothing, and I mean you will probably find nothing, but you may find the classic incidentaloma. There may be some erroneous lab test that really has nothing to do with why they're there, that then you kind of go down that rabbit hole. So I think that's an amazing point of think more about talking to the patient than working them up, and also be aware of the incredibly diversity of common inflammatory skin disease and how they can present, no question. So you kind of hit on that already a little bit in terms of the diagnostic workup. And there's this kind of nice 7 C's of diagnostic workup. And what I like about it is, number one, the first C is confirm the diagnosis and exclude the differential, which we talked about. And when you think about the differential diagnosis of urticaria, It's a lot of things. It can be, even a bug bite to something called Wells syndrome, which is a reactive skin condition that's fluffy and red and itchy, most commonly also from bug bites, but it could be from medications and many other things. There's a rarer autoimmune blistering disease that doesn't always blister called bullous pemphigoid. You can have urticarial pemphigoid, but there's a very long laundry list of hive-like things, which if you're not in the hive category, that could really warrant a workup. But when, again, it's CSU, we are not going to be doing a thorough workup. I think in the C's it says look for an underlying cause. Sure, I think having a good conversation with the patient's important, but not misleading that there is going to be an underlying cause. Now, with inducible urticaria, as you mentioned, yes, there's some external trigger that will set it off. I don't like to think about that as a cause per se in terms of why you have this. Rather, this is something that will set off your mast cells, the amazing factories that produce histamine and a ton of other stuff that results in what we see clinically with hives. But I don't think that necessarily gives you the insight in terms of, well, why does scratching set this off? It's just what we know those are the triggers. An important point, you can have both. It's not one or the other. So for example, if someone has inducible hives, it's important to ask about, in spontaneous urticaria and vice versa, doing inducible testing in the office, which, let's be honest, it's pretty fun. And you want to make sure you're not missing one or the other, because I find, and I'm curious to hear your thoughts, when someone has both, they tend to be a little more resistant to treatment. Have you seen that too?
I think that they're just confused. I feel that we really have to do a better job as clinicians in having that shared decision-making conversation, really helping them understand what our thought process is. And so I think that when there's resistance, we really need to be, in my opinion, checking ourselves and making sure that we're giving them the information that they need in order to make an informed decision.
Absolutely. Now, one thing I do want to highlight is that while not a root cause, inflammatory skin conditions often have comorbid diseases. I mean, it makes sense. Everything is connected. So I think it's really important to recognize that when you have a chronic inflammatory skin condition like psoriasis, atopic dermatitis, and of course, chronic spontaneous urticaria, you can have other similar, from a underpinnings of disease, a biological perspective, pathophysiological perspective, you can have other diseases that come from a similar immunologic root. It doesn't mean one causes the other. For example, we know autoimmune thyroid disease can be common in people with chronic spontaneous urticaria, even atopic dermatitis. It doesn't mean one is causing the other, but that's where, again, a good conversation about other symptoms to work up only based on what's going on with the patient and not just in general, but you're allowed to have more than one medical problem. But again, this is not that one causes the other, rather that they can run together. And then, of course, we want to make the diagnosis clearly. We want to identify any comorbidities. We want to rule out anything else, but then also we want to establish severity and also follow over time. And so there are various tools to do that. They're not really clinical tools. They're more validated research tools, but being aware of how you are one day to the next, I think is important, so that really helps us when we're thinking about what the management strategy is going to be.
Yeah, and what is that management strategy, right? So treatment is the first and foremost thing that we need to turn to are second generation antihistamines. And second generation antihistamines are technically formulated for once daily dosing that should have a duration of 24 hours. But as we know, with chronic spontaneous urticaria or any form of urticaria, truly, we can use up to 4 times the regular dose of the second generation antihistamines, and we know that that's safe. And so that's also something that I think a lot of our colleagues in the emergency rooms, urgent cares may not understand, right? And so we're not always getting that trial of the second generation antihistamine the way that it needs to be done. And that's really the primary therapy that we need to see. If that works for the patient, then that's great, right? And oftentimes it does. But we need to make the diagnosis and get to that treatment point. And so as far as which second generation antihistamine to use in children with urticaria, we really need to keep in mind that a lot of these antihistamines are sedating, right? Actually, all of them are sedating. And so we need to
non-sedating, right?
It's never non-sedating, it's which is less sedating.
Correct.
And I find that different patients respond differently, right? And so there might be one that somebody will say, oh, this is very sedating for me, and then the next person is totally fine. And so it's, we need to just Be aware of that though, especially for our pediatric patients, because they need to function in school.
Right.
And so when we are increasing that dose to up to 4 times a regular dose, they may be more sedated, right? And so we really need to be aware of that, and we need to take that into account as we're thinking about which second generation antihistamine to use.
No, absolutely. That's well said. And I think we know a lot from actually from the atopic dermatitis literature, really advocating against the use of antihistamines because histamine doesn't play a role so much in eczema. But we have a lot of data showing that from a developmental standpoint, a absenteeism and presenteeism perspective, showing up and not showing up, these can have a very detrimental effect on overall engagement. It's all about balance. So in terms of, is this absolutely needed? And obviously with CSU, it is, but treading lightly and figuring out what makes the most sense for the individual child and also keeping tabs on that sedation effect. But to your point, there's been numerous studies showing the safety of going up to that 4-fold recommended dose in adults and kids, but safety doesn't necessarily translate to that sedation piece. So definitely something to keep an eye on. So in thinking about that updosing, it's interesting. Usually when we think about dose escalation in dermatology or switching gears and going to a different systemic therapy, we usually give things a lot of time. When we think about our advanced therapies at the age of biologics, small molecule inhibitors, we're going to give it its day in court. But when it comes to antihistamines, again, specifically second generation non-sedating antihistamines, we're going to rev up quickly. And when you look at the guidelines, whether it be the US or the European guidelines, we are going to go up on that dose almost on a weekly basis until we max out. So we're going to know one way or another if someone is going to do better or do well or respond. And it's funny, I hear all the time, 50% of patients do not respond to the up titration dosing. I try to be positive. I'm like, well, that means 50% are responding. So you have a 1 in 2 chance that that's going to be enough to control your disease. So that is optimistic, I think. So no question, using these medications are going to make a huge impact for a good number of patients, good number of kids suffering with this. But keep an eye on, again, that sedation. Though I would argue many of these kids probably aren't sleeping either because of that spontaneous disease popping up in the middle of the night, which means the parents aren't sleeping. So this is a condition, like many, that does affect the whole unit. So I think certainly that could be beneficial in some cases, but keeping an eye on how they're performing at school is going to be very important.
Yeah, and one thing that you brought up, which was really important, was the impact of the itch, right? Especially at night. And that's something that we really need to be aware of. And secondly, it's the whole notion of, are we starting at, I think about this with asthma management, right? Do we start high, go low, or do we go low and then gradually go up, right? For me, it depends on how long the patient has had those symptoms and how much they're suffering. So I may go high and then slowly taper down, right? Yep. So that they can get relief, and we're not doing this step by step, because as we're doing that step-by-step approach, sometimes the parents don't have any faith in the process and they give up on it, right? And they might just search for a different provider, and then they get lost to follow-up, and there you go, they're in a cycle, right? Of not getting the care that they need when we've appropriately diagnosed them, but maybe we should have just gone with the 4 times right away and then slowly reduced. And so it really, it's provider to provider, the art of medicine, but that's also one thing that I really want to bring up with people is, whether or not you taper up or you just start high and then go low.
Yep. So I think we kind of talked about this perception of being proactive, right? Asking the right questions. And I love what you said. I mean, listen, I'm a New Yorker like you, even though I'm a transplant in Washington, D.C., but I definitely take on that kind of gunslinger mentality of like rev up quickly. And you bring up the important point of maybe start higher, clear disease. And I usually tell patients or their family members, I want you clear. I want you with nothing for typically months before we start pulling things away. And most are okay with that. But it's interesting. A lot of patients are like, if I'm doing better, can I get off the medication? I'm like, don't you remember how bad things were going? But I think there is a process that needs to be trusted and followed. But agree, we want to have a perfect balance of minimizing medication and maintaining efficacy. For me personally, I like patients being on at least for 6 months with no disease activity before we start titrating down. But I think that this is, being a chronic condition, something that requires ongoing engagement, certainly a good communication, not just with the patient, but if it's a kid, the family members, and there should be shared decision-making in terms of what's best for them. And to your point about the sedation during the day, where they are in school too can play a very big role in terms of what you're actually selecting.
Yeah, and the quality of life piece, I feel like we touched on it here and there, but that is really the key element in urticaria and especially chronic spontaneous urticaria, because it's a chronic condition, is that the quality of life piece is number one, what we need to talk about. And practitioners need to focus on sleep. They need to focus on performance at school. They need to talk about missed activities. Is this child missing their sports events because of their symptoms? That really tells us what their morbidity is with this disease state and how much we really need to help them clear their disease, you know? And so that's something important, that once we show the parent also that this is really affecting your child's life, we want to effectively treat their symptoms quickly. And once we get there, then we can start tapering as quick as they want sometimes. I mean, we want to obviously have the patient free and clear for a certain amount of time and make sure that the patient and family understand that we're trying to stabilize these mast cells. We're trying to give them the message that they shouldn't be secreting this chemical, and we need to do that. And this is the message that we're giving to them through the antihistamines. And so it's important to give that message to parents and patients. But once we've established that they have kind of done well on this 4 times dose, then that tapering process, you know, can be done with shared decision making, as you mentioned, and with frequent follow-ups. I tend to follow up monthly, and I use telemedicine a lot. So I love telemedicine for my CSU patients because I can touch base with them. We can both give each other a thumbs up. Everything's going well.
Virtual high five.
Yeah, virtual high fives. All
gotta
of
wipe
that.
that after. But,
you know, and really know that we're in partnership with them in managing their disease, and that we know that they don't want to be taking these medications. We know all of that, but we want them to be disease-free.
I always like bringing up, what is the side effect of not treating? And you hit on those quality of life things. You know, sometimes, especially with chronic diseases, people get used to not being at a normal baseline. They get used to suffering. And so when you get into things like, well, how are you sleeping? How's school? How's social activities? How's sports? And as you get into those individual metrics, the picture becomes very clear of that severity. I think people often underestimate the burden of especially chronic spontaneous urticaria. It's not even on their radar. So when you get into the weeds of how it's affecting daily life, well, those are side effects of not treating. So every decision has a side effect, so to speak. So I really like bringing up, what is the harm of doing nothing? And that really enables better engagement and, of course, adherence to, in many cases, a long-term treatment plan, because being chronic, granted, you know, on average, 5 to 7 years duration of disease, but there are those who have this their entire lives. And especially the longer you have it, and there are some longitudinal studies in children, the longer they have it, the more resistant that a condition is to antihistamines, the more likely it's going to continue. So this is going to be a long-term partnership. So engaging early, I think, is going to be very important. So you heard it first here. Just kidding. You didn't hear it first, because this is a condition that should be out there in the ether. Urticaria is common. Acute, distinct disease, but certainly more common. I myself enjoyed a bout of urticaria on a day when I was about to give a talk on urticaria, so that was fun. But chronic spontaneous urticaria affecting anywhere from 1% to 2% of the population, both in the US and globally. It's out there. It needs to be on your radar, and it needs to be understood how impactful it can be, ranging from misinformation about what causes it to also understanding what we can do for it. And I think finally the future is so bright. We have advanced therapies, newer ones in just recent years and more coming down, to arm us with the tools to better manage this disabling chronic condition.
Absolutely. And we really didn't get into the new treatment options, but there are just so many in the pipeline and so many that we're already using.
It's an exciting time, no question. So, Payel, thank you so much for an amazing discussion. Always fun to get together with you. And thank you so much for joining us for this program.